Hi, Dr. Lachman. It's very nice to have you with us on this episode from Dear ECP interview series. We are very glad that we get to interview someone from Africa, actually. You're our first guest from Africa, and I think that maybe brings me to my directly to my first question. You've been very vocal about African representativeness in the global mental health field. And I know from my friends that a lot of early career psychiatrists aspire to that, to, break from the kind of national work, break into more international work and presence in global mental health. And I wanted to know from your own experience, what advice do you have for early career psychiatrists to aspire to that, who aspire to that?
Thanks for having me. It's always important that we represent well. And I think I often get asked, are you really from Africa? And yes, I am. Several generations born in on the tip of Africa. And I think that's the whole idea that speaks directly to global mental health, that it's not one single thing. And even the idea that you want to break out, like you said, people want to break out from their national confines and have a footprint on the global stage. I think my advice and my experience has been is that you first have to know your context. And knowing your context well means looking beyond just the constraints of what you're taught. And so if I think of child psychiatry, which is my background and my training, a lot of what we were taught originated from places that looked nothing like the place we work in. And it's not just about the patient profile or socioeconomic differences. It is about parenting. It is about what's acceptable, what we think is good enough as a mother or a child or a family. The system is different. And so if we always look towards international waters, if we always think things are better on the other side or better in the West, or that's the gold standard of it, then we lose the opportunity to see what happens in our local environment and to enhance that or learn from it or often teach in a bidirectional way the rest of the world. So I think we have a lot to learn. And the mistake we made is always measuring ourselves up to what happens in an idealized place outside of where we work. So my advice always when I mentor or people that work under in my unit is to say, do you really understand what's happening locally? One of my favorite things to say is Africa is not a country. And similarly, in South Africa, it's not one place. We can have very different experiences where I am in my teaching hospital, 50 kilometers down the road. It's a completely different perspective. And so I think when you know your local context and you try and look at what can be adapted by what's a gold standard or what's, a common literature, what can be adapted locally, you then learn from the community, you learn from your patients, and then it evolves naturally. You become a local expert. And once you're a local expert, then you have, I like to think you have like a box of tricks almost that you can take forward when you're on an international stage or when you're engaging with colleagues and peers outside of your environment, that you have something to offer and they have something to offer. And I think when people see that opportunity, they're much more welcoming. They're much more engaging. It's not one recipe, that you go to more meetings or you engage with more international people. It's about try and find out who the local experts are. And if there aren't any, then you become that. And you become that by exploring and by aligning. I think one of the things in Africa we're very fortunate to have is that sense of collaborative learning, that sense of collaborative caregiving. So it's not territorial. You can learn a lot from people who work directly with families, with patients, with communities. In fact, the most that I have learned have come from community care workers, allied health professionals, nursing, non-government sector workers. And in that way, that builds up your repertoire and your experience.
I see what you mean. Well, that's a very Great analysis, Dr. Lachman. I completely agree with you. And then my second question, which kind of also speaks to the first one, is talking about cultural sensitive approach to mental health research and also clinical work. And it is something that it's a term that we hear often, but I wanted to ask you, how does that translate into the real world, when it's not just a theory, what does it look like in practice to you? Cultural sensitivity.
So I think it comes back to what we're talking about in terms of what does culture and context look like where you are. So I'll give you a good example. A lot of the work that I do is perinatal, infant, maternal, mental health related. So that's working essentially with the caregiver, considered to be always the mother, right? In the most cases, and the baby. And that comes from a very Western idea of how babies are brought up. So, where I am, and which I know happens in many other diverse communities, whether that is in South America or in India or in Asia, children are collectively brought up by aunties, by grandmothers. In South Africa, most children are brought up by extended family members. So, an aunt or a sister or a domestic worker or a nanny, because mothers have to work. So, mothers are not able to always be home and look after them. So, when there are issues in the relationship between children and their caregivers, whoever that primary caregiver, it may even be the father, it may be same sex couples, it doesn't matter, whoever is the primary caregiver of the child, we have to be able to target and tailor intervention to them, right? But when we look at what's available for early childhood interventions and early work with babies, all the work that originates from North America or Eurocentric contexts focuses on a mother and a baby. Now, what do you do when there isn't a mother that's looking after the baby? Not because the mother is dead, but because the primary caregiver is someone else or collectively. And so, does that mean all of a sudden our parenting is incorrect? Or that we must say, in order for us to intervene, we need there to be a mother. So let's bring this mom in and let's do the work with the mother, but she's not the person who takes care of the baby every day. That for me is a very simple example of how we have to take culture into context. Culture is not some far removed things about, oh, traditional healing or, it's kind of historical, ancestral patterns that are coming. All of those things matter. But culture is also about what is acceptable and common practice in this environment. And so when I think about what's culturally sensitive and what's context specific, that's what we mean. We're saying we know what's a gold standard treatment, right? We work with the mother and the baby. But what do we do when there isn't a mother? There's a grandmother, there's an auntie, there's a nanny, there's a creche worker. Is there nothing we can do? Or are there still some principles that we can adapt or that we can expand to do that? So when I think about keeping that in mind, always ask yourself, right? Is it good enough only if you have, for example, if we say, how do babies eat, for example? Do they have to pick their own food? There's a thing on social media about allowing babies to lead the weaning. It's called baby-led weaning, right? And if you ever watch it, you'll see these little babies who are offered plates of food. And so they pick things in different textures and they taste it and they throw it down. And then, the mothers say, this is ideal because it's baby-led weaning. It's what the baby wants. But I challenge you, I say, in a context like ours, or I'm sure in Asia, also in South America, in other limited resources, lower middle income countries, that's food wastage. In a place where there's food insecurity, where the baby eats first and all the other children and the adults eat last, why would you do that? Why would you allow a baby to throw things and waste food, and kind of when there is food insecurity? What's the right thing to do? Well, the right thing for that space and that situation is to offer the baby a balanced meal or safe food that you can afford, that is good nutritionally for the baby, and you teach the baby to eat that. Now, there's nothing wrong with that. But if we looked at it only with the Western lens that said baby-led weaning is the gold standard of how babies must eat, then we would look at this poor family and we would say, what are you doing? Why are you forcing this baby to eat something? The baby should choose. So a lot of these things you learn as you work with children and you work with families, that there's no rule, there's no manual that's going to tell you this is the only way it needs to happen. What's going to inform it is the environment and the culture, the community, and the reality of life, right? You said, what's the reality of clinical practice? The reality of clinical practice is that people are poor. People face these harsh realities of psychosocial adversities.
Finally, with my last question, although the conversation is so interesting, Dr. Lachman, I think we could talk for hours, is about child psychiatry. What would you like to say to trainees that are maybe unsure about this specialty, or maybe kind of things that they should consider, or things that you see them misunderstood in child psychiatry?
I think child mental health is everyone's business. I think it all starts early. There is no way you can treat an adult without an appreciation and an understanding of their early childhood experience. And the beauty of it is when you are in a field like child and adolescent psychiatry, you have an opportunity to intervene. It's this magical time where, we talk about early adversity, we talk about adverse childhood experiences, we say the most amount of harm can be done in this time. But we very rarely talk about the fact that the opposite is also true, that it's a period of intense, a critical period of brain development, right? In childhood. So in two spikes, first 1,000 days, and then again in adolescence. And what's really lovely about that time is while it's true that the adverse events can have the worst and most lasting impact, it also means that if you intervene early, if you have positive engagements, if you're able to change a trajectory, it can have the best outcomes. So you have an opportunity to implement change, to optimize development, to give people the best chance in life if you intervene early. And in my mind, I always think, why would you not want to do that? It's one of those subspecialties where you look at it and you think, oh my goodness, this poor child, what can I do? Actually, you can do a lot because you're not seeing somebody who is now already in their 40s or 50s and had this really hard life, and it becomes so much harder to impact, right? So I think people misunderstand that it's not all about, psychotic children or children on the spectrum who are really challenging, who we really struggle with, and it's not always heartache. It's sometimes a lovely opportunity for you to implement things in a positive way. And I think that's important because working in mental health itself is so stressful and it can be so impactful on your own mental health and your own ability to see the world through these lenses where you think, there's so much bad that happens. I think child psychiatry is one of those specialties or subspecialties where you can see there's so much good that you can do. And who wouldn't want to? I mean, my PhD was looking at positive engagement and shared pleasure interactions between parents and their very young 6, 7 month old babies. And I mean, think about it. What a pleasure to be doing a PhD or to be doing a study where you're looking for good rather than looking for just the bad that happens. Because that's what life is, right? It's a spectrum of good and bad. So I feel people misunderstand that sometimes. And most child psychiatrists, people also say things, well, I would know if I'm not a parent, if I don't do that. It's simply not true. You have such a lovely opportunity to be able to parent in ways that maybe you wouldn't have had the opportunity if you didn't have your own children, or if you are in situations where, you miss a family. You have that potential to make huge differences and meaningful change in the lives of children and their families. So I always feel like child psychiatry is sometimes a poorer subspecialty because there's no major interventions. You can't do all these really fancy things or use medications like you want. But it also offers you sometimes a simple way in which you can have a lasting, even economic impact later in life. Because I mean, there are wonderful studies in terms of economic cases for intervening early. That you have better outcomes later in life if you're able to meaningfully change that trajectory. So I would encourage psychiatry residents or early career psychiatrists to think that number one, child mental health is everyone's business. And number two, if you're looking for a field which basically allows you to straddle both the pathology and the potential, then this would be it.
Very well put. Thank you very much. Thank you for such a lovely and engaging interview.